Strategies for partnering with UFOs for sustainable health systems development. I guess I didn't get the memo. In this case, UFOs means unusual FBO opportunities for sustainable systems development. And I'm going to look at a fairly specific, narrow, this is a very broad topic. We could collaborate, partner with FBOs at every level of the health system, from the community to the health post, to the health center, to the hospital, to the regional depots, to the national level. But I'm going to look at a specific case within that. My work in Congo spanned 3 terms of service from 1972 to 1991. Each term was marked with a special present that we brought home with us. The first 2 terms were, my wife and I were volunteers with a group called Mennonite Central Committee. Anybody knows? Heard of that? Yeah, okay. I first went to Congo as a teacher to teach biology, ended up teaching physics and art for 2 years. Got interested in tropical medicine, and MCC said, well, if you sign up for 5 more years, we'll support you wherever you want to go to get a master's in public health. And I said, okay, we'll do that. And where did I go? I came to Johns Hopkins. I got a master's of health science and tropical medicine from Johns Hopkins in 1976. Went back to Congo for a second term with MCC, and that's when I worked with Dr. Dan Fountain at a place called Vanga to help make Vanga one of the first health zones managed from a Protestant hospital. After that, I went to Tulane, got a doctorate. Just as I was finishing up my doctorate at Tulane, I got a call from AID saying, we have this new project that we want to create 50 Vanga-type programs across Congo. Are you interested in being the project manager? So I said, yeah, great. So it was a very unusual situation. For the next 10 years, I was a contractor to AID, paid by your taxpayers' money, to sit at the Protestant Church of Congo to manage a project, a large public health project, on behalf of the Ministry of Health. So this was a period of time, instead of contracting out to the MSHs or the JSIs, it was the Protestant Church of Congo that managed that project on behalf of the government, and it proved to be a very successful approach. By the end of 1991, we had helped create 306 decentralized health zones across Congo. Each of those health zones serves a population of about 100,000 people. It's kind of like a county health system. In other countries, they're called health districts. Congo chose the name health zone. What's particular in Congo is that half of those health zones were managed by churches, by the Catholic Church, by the Protestant Church, or by other NGOs. We always hear this statistic that up to 60% of health services in sub-Saharan Africa are provided by FBOs. Well, that's true in Congo. It's about 40% of health services are provided from FBO health facilities. But in addition to that, 40% of the health system is managed by FBOs. And that's quite a different role, quite a different partnering role between the Ministry of Health and Congo that does not, as far as I know, really exist anywhere else. And I've still been trying to figure out why that is. Why can't we apply this model elsewhere? And it was sustainable. In 1991, things kind of fell apart in Congo. The Sanru project was closed. The next 10 years was a civil war in Congo. In 2001, WHO, as that war was ending, WHO and UNICEF came and did a survey, and they found the health zone system is probably the only system in the country still recognizable as a nationwide quasi-state structure. And even with critically little or no support, it commands allegiance and support from health workers. That, I think, is a great definition of what sustainability is about. The health zone concept survived the Civil War of Congo at points when Congo was occupied by 7 different rebel groups, or 7 different invading countries, if you will. the health zone systems continued to function in those rebel-controlled areas. Now let's switch a little bit and look at Haiti. Haiti's another special case. Here's a map of all the NGOs in Haiti, all the known NGOs in Haiti. I would say for every known NGO, there's probably 10 unknown NGOs, kind of like what they say about cockroaches, you know? You see one cockroach, there's another 100 that are invisible in the wall. That's kind of the way NGOs are and FBOs are in Haiti. They're everywhere, and it frustrates the Ministry of Health. The Ministry of Health says, we can't work with these FBOs. They don't work with us. They don't follow our rules. They do their own thing. There's just too many of them. And the second challenge that the ministry have is that they have a constitution which says that they will devolve their management, their governance, to the commune level. There are 140 communes in Haiti. So when that decentralization happened, people said, oh, great, each of the communes is going to become a health district. We're each going to get a hospital. Well, there's less than 50 hospitals in Haiti. So, you do the math. It just wasn't feasible to do that. That was at a point when I was working in Haiti with the International Development Bank, and we came up with a strategy to redefine these communal health units to include 2 or 3 communes together. And at the same time, to work with the ministry to say, okay, forget all of the FBOs, concentrate only on the FBOs that are managing hospitals. Concentrate on Pignon with Guy Théodore. Concentrate on Hospital Albert Schweitzer. There's 20 or so faith-based hospitals. Concentrate on them and how you can partner with them in health systems building, and then the other partnerships will to fall into place. And so that's what they have done, and there has been some success. I would not say great success, but there has been some success in this UCS concept working around the Hospital Pignon, around the Hospital of Albert Schweitzer. That's the kind of concept that I'm interested in looking at. And I keep coming back to an old school paradigm from David Korten. In 1985, okay, so this is 30 years ago, David Korten came up with 3 generations of development strategies for NGOs. And we can apply that to NGOs and FBOs. And he said, all NGOs are usually created or apply one of these 3 strategies. The first generation NGOs are those that work in the emergency mode. And if you look at the history of NGOs, many NGOs, SAVE, CARE, Mennonite Central Committee, were all created in an emergency mode. Mennonite Central Committee was created after World War I to help the problem with famine of Ukrainian Mennonites. Well, that's kind of disappeared from their radar, and now they're known more as second generation development workers, where they work more with the community. So first generation is today it would be medical Doctors Without Borders, which is the kind of the standard for those that work with first generation for medical emergencies. Others have moved to community development, working with communities more as partners rather than as doers, more as mobilizers. But Korten said, we need to take that to a third generation. And the third generation he called sustainable systems development. And that's where an NGO works at a higher level with a district, a region, or the nation in doing health systems development together as a public-private collaboration. The role of the NGO is more as a catalyst rather than as a doer, and the key aspect of it is strategic systems management. Now, I'm not saying that 3 is better than 2 is better than 1. All 3 are really necessary. Like in primary health care, we talk about curative, preventive, promotive care. We need all 3 of them. Same thing here. We need all 3 of these. We need an integrated approach so that we're ready to do 1 and 2 and 3 when there is the opportunity. But my experience is that FBO partners have never really opened their eyes to doing third-generation health systems development. Consider this situation. Here is an administrative zone, and has a nice little river going through it. It's called the Quilu River. Actually, this is Vanga, where I lived for 3 years. Upriver was Vanga was a Protestant hospital, and around Vanga there were some red health centers that were developed by the American Baptist. Downriver was a Catholic hospital at Juma, and upriver was the state hospital at Balungu. This geographic area, as an aside, is also the geographic area that is featured in a book called the Poisonwood Bible. If anybody read that, I can relate to this from that. There is a supposition that she wrote it with Vanga in mind. But that's an aside, literally aside. But for many years, the Congo system was this. The Catholics, the Protestants, and the government working together, working in parallel with 3 different systems. With 1975, 3 years before Alma Ata, they came up with a vision of creating decentralized health zones. And there are various options to consider here, and this is the point I'd like to make. In traditional decentralization, the way most countries approach it, automatically the government hospital would become the head of the health zone. It would be the reference hospital for the health zone. It's where the management team for the health district, it's where the management team for the health district would be placed. And the other hospitals in that district would become a secondary role. That doesn't, I think, make the best use of the FBO resources. Another option in some countries is that the FBO hospital has been recognized to be the health district reference hospital, but that the district management team will be located someplace else. This is the model that I found when I worked in Cameroon back in the 1990s. There were several large FBO hospitals. They were designated to be the reference hospital for the district, but only for reference curative care. They did not have a role in managing the health services, the preventive or promotive services. Another model is that those 2 services will be designated to one institution. In this case, a district reference hospital, the management team are at the same hospital. This is an example of Liberia, Bone County, so they use the county system, but Bone County is a Methodist hospital which is designated to be the reference hospital and to manage the county. Or the final extreme is in Congo, where the 3 are divided and each one becomes its own health district, or in this case, health zone. Now that sounds like balkanization, but it's only applicable in situations where the population is sufficient and the infrastructure is sufficient to justify that. It has worked great in Congo. It's not very applicable in other countries because they don't have the same configuration. In Congo today, there are now 516 health zones. Of those, 40% are managed by FBOs. My concluding recommendations are this. To look at this kind of partnership, you should consider third-generation health systems development with FBOs by assessing their hospital infrastructure to support the management of health districts. It sounds like a curative bent, but if I'm going into Togo to assess the possibility of this kind of a partnership, the first thing I'll look at is how many FBO hospitals are there and what is their capability or interest in collaborating with the government. And it's at that level then that kind of discussion can happen. And it's not just the capacity of the hospital, it's the capacity of the hospital to provide electricity, to provide a garage for vehicles, to provide schools for the children of the health professionals. Second recommendation, in decentralizing health systems with FBOs, consider flexible rather than rigid administrative boundaries. And this is where most countries get caught up. They get stuck in doing decentralization by administrative boundaries, and that always forces the leadership to the government, because the government's in the towns. The FBOs are out in the rural areas, which would not logically be the center of the administration. Third, have FBO-owned facilities serve as the official health centers with their own catchment population. Don't just negotiate with the government that, yeah, we'll help deliver health services, but make it a negotiation where your facilities become recognized as official health centers as part of the health system. That's the way Liberia has done it, and I think they've been very effective. And fourth, watch out for other UFOs. Thank you.
He is creative. Thank you very much. You do. You do. Next, we have Dr. Samuel Mwenda. Many of us know Sam. He's the General Secretary and CEO of the Christian Health Association of Kenya, CHOC, a national network of Protestant church health facilities and programs from all over Kenya. Prior to his time at CHOC, Sam served for 6 years as the CEO of the 250-bed mission hospital in rural Kenya, a Methodist hospital. He has also worked as a medical officer for the Ministry of Health in rural Kenya. Dr. Mwenda also serves on the board of directors for IMA World Health. He is a man of deep humility, compassion, and generosity. And I believe that many of us have learned a lot about the spirituality and the empathy it takes to be a part of the global health movement. When I asked him for his fun fact, he said, "My fun is found with my family. I have 1 girl and 2 boys, and what we do for fun is spend every weekend together. For we work very, very hard during the week, but our weekends are family fun weekends, so they're missing me right now." Sam.
Thank you very much. Good evening. I'm very glad to be here, and I appreciate the opportunity. This time around, I thought I'll bring some, I'll share some experiences about work we are trying to do through partnerships in addressing non-communicable diseases. Because non-communicable diseases have become a huge, growing burden in our country, in Kenya, but also I know in many sub-Saharan African countries. And a lot has been done in investing in work around communicable diseases, but not much has been done on non-communicable. So you've been told, Chuck, we are a national network. We are celebrating 70 years this year. So it's a special year for our organization. And our members are a wide range. They include medical training colleges, as well as community-based healthcare organizations. But what is most important is that we embrace partnerships. And because we know we can't do it alone, government, Ministry of Health, county health departments, development partners, other Christian health associations, the private sector as well. This would summarize who we are and what we are committed to and how we do it. Our goal really is to promote access to quality healthcare for the communities that God has provided to us to serve. And in a number of ways, we have various approaches to service delivery, health system strengthening. We work on strengthening governance and leadership, but also continually engaging in advocacy, in lobby, and partnership building with government, but with also various other stakeholders. We are excited that the new global sustainable development goals, the health agenda, has included non-communicable diseases, but also has provided encouragement for partnerships, because we see this is the only hope for dealing with many of the challenges that we have. The Ministry of Health in Kenya has embraced the need to prioritize non-communicable diseases. I got this slide from the Director of Non-Communicable Diseases in Kenya, and just highlighting the risk factors that we are facing, even in the rural areas. And I'm sure there are things you identify with. The non-communicable diseases, there are four major ones: cardiovascular diseases, diabetes, cancer, chronic respiratory conditions, but also mental health, and particularly drug abuse and a lot of alcoholism, and then injuries from accidents and so on. So we do have the risk factors. And in terms of estimating the burden, cardiovascular diseases are causing about 8% of the mortality. That's from WHO fact sheet. Diabetes, we have about 4.7% prevalence rate, and the rural areas are not left behind. Even though 10.7% is in urban areas, we have about 3% in the rural areas. And the annual incidence of cancer is estimated at about 37,000 new cases every year, and about mortality of about 28,000. So our Kenya health policy, which takes us to 2030, and the strategic plan have prioritized universal health coverage for not only communicable diseases, but also non-communicable diseases and reproductive, maternal, neonatal, and child health services. This may illustrate, some of those risk factors. Even the rural areas where ordinary people are used to walking and doing manual work, we now have motorcycles. We call them boda-bondas. So you can see even going to the market with a cow, they don't need to walk anymore, even from grazing. Sometimes lifestyles have changed, and nutrition as well, and consumption of unhealthy products. So in our strategy as CHAC, we have a number of components. One is address education and awareness to communities. Also empower health workers through capacity building on non-communicable diseases, and particularly to be able to support task sharing. We no longer talk about task shifting because you get conflicts between doctors and nurses and the others. It's about sharing. And we do screening, supply chain for, and we are grateful for some international pharmaceutical companies which have come in with access commodities. We have treatment, and then M&E. We are trying to promote linkages between the health facility, the church, the community, the marketplace, reaching people where they work, where they live, and also building on lessons, particularly from the HIV response. Those who were in this room earlier, you may have seen this model. From work we've done in HIV, we've done it in family planning, we found it also works in mobilizing communities for non-communicable diseases, where we link health facility. We have a relationship with the Ministry of Health because they do policy, guidelines, protocols, and training materials. The church, church leaders, church groups, community health workers, or volunteers, the supply chain, and for us, we have MEDS, which is a faith-based organization, and then the private sector, our development partners. In fact, a lot of funding support now is coming from the private sector. And all of us, our motivation is we are committed to promoting, identifying people who may have these non-communicable diseases and referring them to quality care. These are the counties where we are implementing an hypertension awareness treatment project. It's 23 counties, Kenya has 47. We are working through 113 FBO health facilities. In the last 1.5 years, we've trained over 450 community volunteers, 134 religious leaders, and about 329 healthcare workers. When we went out to share the model with religious leaders, they were so passionate about this. In fact, I remember some bishops telling us, why don't you also equip us with a digital blood pressure machine so that as people leave our church service, as we greet them, we can also check their blood pressure. And actually, we found that was more than we were asking. We were just asking of them just to share the messages. So within a short period, through their commitment and support, we were able to reach nearly 2 million people with awareness messages, and these are documented. When you talk to the number of people that you talk to, these are the ones that are registered, and we've been able to screen over 900,000. Actually, it was many more, but we decided we want to keep those that have been put in the register. And we identified about 140,000 who have had abnormal blood pressure, either one of them or both of them, systolic, diastolic. And the project created this pathway, awareness, screening, referral to the health facility, those that are actually diagnosed, confirmed by the health workers, then put on treatment. And the next level is work through retention and ensuring control. It's work on progress. The first 2 areas we've done extremely well. Initially, when we started, things seemed to be a bit slow. We had a target of about 100,000 people reaching screening 100,000 every month. And it seemed like it was a happier task. But when we had enough people trained and materials provided and a system set, we actually started way surpassing that target. And after a couple of months, we were told, no, you need to slow down. We've already screened too many people. Let's work on getting those identified into the health facility for treatment. That's where we are now. In terms of treatment, we've started getting increasing numbers of those that are enrolled every month, the new cases. We like to do a lot more, but that's the general trend. We're also doing work on diabetes, and what we found is that about 30% of the people living with diabetes also have hypertension. In our program, we have more women that we are reaching than men. We are making a lot of efforts to find men. As always, it's a challenge. There are a lot more women that we are able to reach. This represents, part of the work, a lot of mobilization in the communities, using church groups. This is a women's group of the Presbyterian Church. After their activity, one of them is checking their blood pressure of the team and has these registers that have been provided at community level where they take all the indicators. So the messages are passed during church services, and then people are persuaded, the community health workers become available to do the screening. What have we learned? The need for capacity building to facilitate task sharing. The need to provide tools which are aligned to Ministry of Health policy. Initially, the register that we had we were not getting that much data, and people said, we need to have something that is endorsed by the ministry, because that's what you are used to. So that we found it to be key. There's great potential in engaging churches, religious leaders, and community health volunteers, and creating linkages with health workers at the health facilities. Partnership are key for NCDs as well, and the health system strengthening to cope with the double burden of disease. We have had a lot of investment for communicable diseases, and many times they have been, just limited to that. But there's need to broaden the strengthening so that the health workers and the system can cope with this. We need to utilize the lessons from HIV. There's so much that has been developed, particularly on the treatment cascade to strengthen patient linkages and also follow-up to assure adherence. And there's need to build data for policy and resource mobilization advocacy. It is through this project that the minister has actually now put together a technical working group, and they have developed a national policy on non-communicable diseases, and they're advocating. They are getting more resources getting allocated from the ministry budget. Something I've not put here for diabetes, we have psychosocial support groups, and where we found that the patients have been organized into those, their treatment adherence is much better, and they get very empowered because they keep sharing lessons and experiences. Moving forward, we are working on a new strategic plan as CHAC, and we expect to expand the scope of our priority focus to include NCDs, universal health coverage, and health system strengthening. We are working on transitioning from the pilot to a full NCD program, and we've actually started a unit led by one of our doctor colleagues. We have decided to integrate all non-communicable diseases. At the health facility, we are encouraging them to have both hypertension and diabetes clinics put together, and we'll focus on building a complete treatment cascade. The main gap was linkages to treatment, to the facilities, and ensuring that we can account for the people that we've screened. So we are changing strategy a bit. We want now to work with the health facilities to go out, do outreaches, do the education, the screening, and enroll those that are identified immediately for treatment and refer them to the health facility. Strengthen data, that's key. Besides this, there's also another area that is quite exciting. We've had infrastructure challenges in many FBOs. We thank God there's a new, quite ambitious project, actually, that is at an advanced stage. A partnership between an academic institution, one of the faith-based universities, CHAC, development partners here in the US, we are very excited, and GE is a part of that partnership to develop regional teaching, research, and referral mission hospital, but it also include linking it to 23 other mission hospitals for medical education, research, and service referral. So this is something that we're excited about, and we are praying that it will get started or accomplished soon. Already partnership in the training has started for family medicine. We are already doing it in 3 hospitals. Program started at that university. I want to acknowledge these are the partners we're working with. Novo Nordisk is for diabetes, AstraZeneca is for hypertension, Novartis has come up with for a number of conditions, respiratory conditions, hypertension, diabetes, and also breast cancer. Roche and Siemens are giving us support for diagnostic equipment, and then the ministry, Danida, and MEDS for supply chain. Thank you.
Great, thank you so much, Sam. Next and last, we have Jean Duff. Jean leads the Partnership for Faith and Development, supporting faith groups in their work with governments and international, public, and private sector bodies. She serves as coordinator of the Joint Learning Initiative on Faith in Local Communities, facilitator for the Global Religious Forum of the World Humanitarian Summit, project coordinator for Faith and International Assistance, and advisor to the Interreligious Program Against Malaria in Mozambique. I don't know when she sleeps. In 2008, she co-convened the Women, Faith, and Development Alliance. She is a visiting research fellow at Trinity College in Dublin. She has an MPH from Columbia University and an MA in clinical psychology from University College in Dublin. Jean is a bridge builder. She's a strategic thinker and truly a beloved collaborator. When she is not traveling for work, and as you've just heard, that's not very often, but when she's not traveling for work or working, she likes to go back home to North Mayo on the Sea, where her neighbors actually speak Irish. Welcome, Jean.
Giasmurigi, Kanastatu. All right, I won't deliver it in Irish. I wish I could, actually. Well, great to be here at another CCIH conference, and I understand the biggest and best ever. Great energy, and thank you so much for having me. Amy asked me to look at the topic from, if you like, the 30,000 feet, and I'm delighted to be able to follow Frank and to follow Sam, because they so hugely illustrate the sort of the bigger picture, top-down perspective that I'm going to bring. It's a really exciting time, I think, for all of us to be involved in this work as faith-based organizations working in the health and development space. Because those of us who've been around for a while know that there's really a lot of movement. There's an opening. I think the scale of the goals, the scale of the challenge, both in the development and the humanitarian world, is really pushing the necessity of innovation, and is pushing people, maybe secular folks or whatever, who might be quite opposed in many ways to partnering with faith communities and so forth, pushing folks to look at new ways of doing business, and I think opening tremendously to the possibility of working with faith-based organizations. So today I'm going to do a fast gallop. Those of you who've heard me speak before know that I will go at a fast clip. The slides are going to be available, I'm told, for everybody, so don't worry about taking notes on the references and so forth. I'm going to look at how I see just a couple of examples of religious leadership on an international scale, and indeed secular leadership, public sector leadership on an international scale, as setting a context for the kinds of innovative partnerships that Frank and Sam were talking about. And I'm going to then take that back to some generic questions about what Christian faith-based organizations can do within these global contexts to forge effective partnerships and to scale up. So just figuring out now how to work this one. No? Oh, this. Okay. Thank you. Great. So we certainly do have some amazing religious voices for the poor, for development at the present time. Pope Francis, the Holy Father's sort of timing on his leadership just couldn't be more extraordinary. You know, of course, that this is a photograph of him speaking last year at the launching of the Sustainable Development Goals at the UN. And he's a man who I think so many of us admire, not only for his incredibly strategic use of the Vatican megaphone, if you like, but also for his personal faith and his demonstration of walking the walk as well as talking the talk through his personal gesture. So he sets a very important standard. I'm really interested to see within other faith communities opening and changes in leadership. And I think one of the most significant things that's occurred this year earlier in Morocco was a gathering of 120 Muslim scholars from many, many countries in Marrakesh to look at the question of Islamic responsibility to religious minorities, which of course has been such a massive issue in many Muslim majority countries, and certainly for those subjected to religious extremist practices. So I commend the Marrakesh Declaration to you as an example of Muslim leadership. It's a beginning. It ain't there yet, although it does advance a notion of jurisprudence of common citizenship, of basically equal rights for minorities. It references, it grounds its declaration in Islamic tradition, and unfortunately doesn't at all reference humanitarian law and the international rights. But nevertheless, it's an extremely important piece and worth looking at. I'm only picking one or two out of a vast number of areas where we're seeing very high-level religious leadership within traditionally secular places. So just last week at the World Food Program, again, the Holy Father spoke. He visited the headquarters of the World Food Program, addressed a meeting there. Many of you will be aware of the International Zero Hunger campaign, and what's interesting is to see an interreligious response now, an interreligious commitment to engaging in the action. Within the public sector, I think this year one of the most interesting developments has been the launch by the German Ministry of Development and Economic Cooperation of a new bilateral coordinating mechanism. So this is a place within the German government that is intended to bring other governments, already the US, the Norwegian, Canadian governments and UN agencies together, to basically advance within their own governments the possibility of religious engagement. I think this is an incredibly important strategic place, and I'll be coming back to this later in my remarks to ask you to think about what you can do to help them do a great job of talking to their colleagues. Some of us in the room were at the World Humanitarian Summit in Istanbul a couple of weeks ago. We worked very, very hard. We had to work very hard within a highly secular UN environment to open space for the religious community. It was extremely challenging, but there was considerable success in opening that space. There was a special session on religion and humanitarian response. The Joint Learning Initiative on Faith and Local Communities, which, as Amy said, I coordinate, had a side event on the big question of evidence for faith groups' contributions to humanitarian response. In spite of having opened the space, nevertheless, we have a long way to go. Talk about baby steps. The religious community's engagement and evidence and so forth was not included in the chair's summary, which was the first outcome document from the summit. There are some important next steps that come out of that, which you'll see later. I'd like to mention, again, many of you will have heard about an initiative convened by the World Bank, by Adam Taylor, who I know has spoken here in the past. I'd like to mention the so-called moral imperative, which was launched in April 2015 and endorsed by a large number of diverse faith leaders from different faith-based organizations and faith traditions. That group has gone on to partner with faith-based organizations and JLI and others to launch last year a new faith-based action framework, which I think is a very interesting framework for collaboration across faith groups, Christian, Muslim, Hindu, Baha'i, in support of the Sustainable Development Goals. So it's a frame of reference organized around 3 work streams: evidence, collaboration, and advocacy, which allows us to look at our collective impact, our collective contribution, and our collective impact. There will be a meeting, just to flag calendars for those of you who may be at the UN General Assembly, there will be a meeting of the Faith-Based Action Framework Working Group, most likely on September 22nd, and please be in touch with me if you would like to be noticed on that meeting. So these guys are talking. This is a wonderful photograph of President Kim and Pope Francis, who have had a number of conversations about the preferential option for the poor and how we might work together. I guess my rather cynical question is, okay, lots of talk, where's the action? And how are we going to translate this really interesting and exciting leadership? So these voices, this personal leadership, this strong leadership, how are we going to translate it into those effective partnerships that we're talking about? So I'd like to summarize out of many, many opportunities that would exist, a couple that I think are interesting for consideration by the group. First of all, I'm really excited when I think about the faith community's opportunity about the so-called localization agenda. They've been talked about in many ways, and USAID, for example, has now for many years been committed to pushing more resources to local partners. 27% went to local partners in FY17, so it's moving in that general direction. One of the interesting things I learned at the World Humanitarian Summit was that there is now a goal to shift resources from the current 0.2% of resources going to local and national networks, only 0.2%, it just seems mind-boggling, to up to 25% in a very few years. What an opportunity for the faith community. It's an absolutely extraordinary opportunity. So the next thing to tag is just a big, big push towards Global South leadership. You will be aware of the launch of a new network, a new NGO network called the NEAR Network, which focuses particularly on localization and capacity building. We're observing a very strong movement again, and I know those of you who've been around for a while will see this pendulum swinging back to a holistic approach, and in particular, an integration across the development and humanitarian spectrum. So for those of you working in health, I think there are a lot of new opportunities to think in terms of generalizing the fantastic health work that you do into humanitarian settings as well. Tagging financing for development. Financing's way longer conversation. A lot of the structuring is changing, and I would really flag the religious resourcing piece of that. Tremendous resources flow through our systems and our networks, and I think that there are interesting opportunities associated with that. I think faith influence, and Sam's wonderful example of the mobilization on blood pressure is very pertinent. Faith influence is now well recognized as having an impact on key attitudes and behaviors for development, and I think we have to make much more of that. And finally, we're in a very strong position as faith community in conflict and fragile states to make a big difference. So in terms of building on these effective partnerships, how's my time, Amy? Oh, 3 minutes. Okay, a couple of minutes. So I'd like to flag the McKinsey report on conditions for effective partnerships and refer you to the Joint Learning Initiative website for the actual report. Again, not surprising from your experience, of course, limiting factors on partnerships include lack of knowledge and understanding, structural challenges from going from big organizations to small local entities and how we engage, and then a question, of course, the lack of evidence. I'd like to run through quickly, just to tag 5 ways that I think Christian faith-based organizations, all faith-based organizations, can move to strengthen partnership. You won't be, those of you who know me, won't be surprised that I take a whole slide on evidence because it seems to be really now so critical that we just have to do a better job of collecting the data, exchanging information, aggregating data, taking it up from our own small case studies into larger reports. We need to affiliate with local academic institutions, and I know many of you already are. We need to intentionally target gatekeepers and decision makers for presentations of evidence, very, very intentionally and specifically. We need to understand their concerns and what information they actually need and want. It may not necessarily be what you want to tell them. I've seen the extraordinary power of friendship and trust, and what an important vehicle that is for persuasion. Publicizing these new partnerships and the methods and mechanisms that support them. And I encourage you to consider joining also the Joint Learning Initiative on Faith and Learning and local communities, and particularly participating in one of the learning hubs. The other 4 ways, just again to tag, and perhaps we'll have time for some discussion. I note the paradox of staying local, which of course all our work is. I mean, any impact from a faith-based organization happens one-to-one and at the front lines of care. But also scaling up. So how do we live into the holding on, maintaining our robust faith identity, maintaining our institutional identity, and at the same time becoming big enough and scalable so as to be able to do business, if you like, with larger organizations. I particularly note they're joining national ecumenical and interreligious partnerships. We've talked a little bit, and Frank mentioned it in particular, about capacity building. To take advantage and to actually live within this new localization agenda, we need to take very, very seriously the capacity building requirement and to note that a massive scale-up is needed. Faith-based organizations need a crash course in development literacy on a very large scale to build accountability and transparency skills. I love Sam's example of mobilizing congregational networks. I mean, the power of large-scale mobilization of faith leaders is absolutely extraordinary. And of course, they proceed holistically. They're not just interested in blood pressure. We need to demonstrate conformity to core professional standards. We need to think about using our faith funding and to facilitate and amplify powerful faith voices for influential advocacy. And again, this is a rather fuzzy slide of 2 of my favorite people, the Sultan of Sokoto and now Cardinal John Onaiken. Examples of extraordinarily powerful, influential faith leaders who, if partnered and if we go after them and work with them and empower and equip them, can literally move nations, in this case, around malaria in Nigeria. And just finally, on advocacy, and as Amy said, I coordinate the Faith for International Assistance project. I know Shepard Smith was here yesterday to tell you a little bit about it. But I think that we don't yet take seriously enough the power of influential advocacy by faith leaders and being intentional about facilitating that. I know the African Christian Health Association platform and CCIH are very active in this space and doing wonderful work. Chad Hayward is here from Accord, and there's a network that is also looking at increasing the advocacy by faith leaders. Faith for International Assistance focuses on the US budget and the funds that are allocated to poverty-focused development assistance. And we bring faith leaders to Washington to talk to members of Congress. So again, to tag that. So here we are at this paradox of local, one-to-one, one baby at a time, but scaling up at the same time and looking creatively and I think innovatively at new partnerships and new ways of partnering to make more of a difference to more people. So sorry, I went a little bit over there, but thank you very much.
Wonderful. Thanks to all of the panelists and all of you. I know we are running late. Can I take, I'm looking for Mona. I don't know where she is, or Kathy. 3? Great. 3 questions, if anyone has a question to ask. And do we have someone with a mic? Great, thank you.
This is for Dr. Mwenda. My understanding is that about 5 years ago, the government of Kenya separated into 2 separate ministries, the public health prevention versus the medical curative services. Now, if that's the case, how has that either helped or hindered your work in NCDs with CHOP?
Yeah, we'll take them all at the same time. The next question. In the back, thank you.
Hello, thank you very much to all the panelists. My name is Karen Sichinga from CHAS, Churches Health Association of Zambia. Jean, when you said the current, I think your slide headed current opportunities for FBOs, and you also mentioned that 2%, the opportunities that 2% of the funding has increased from 2% to 27%. To local communities. How do you define local communities? Because our experience, sometimes local communities means an FBO from Washington, based in Lusaka, and receives 27%. We do not consider that local. How do you define local?
Thank you, Karen. And our third question. Okay. Go right ahead. Yeah.
Hi, my question is for Jean. I work for USAID and have the privilege of working on a South-led project, but we have seen a lot of frustration and management challenges, and so my question would be to you as we kind of shift towards this, maybe offering some practical ways we could kind of ease that transition and that bridge and that frustration coming from a faith-based perspective.
Thank you. And I'll ask each of you to please come forward as this is connected to the video. So Dr. Mwenda, if you would take the first question, please.
Thank you, Ron. The situation has changed. We adopted a new constitution in 2013, and after the elections, under the new constitution, the new major reform in the health sector, we have one ministry, but the health services have been devolved to the county governments. So the ministry at national level is dealing with the policy, regulation, resource mobilization, and partner coordination and training. The counties, for 7 of them, each of them is responsible for service delivery. So our new challenge is how to effectively engage at the 2 levels, because the counties are more or less semi-autonomous units, and each has a health structure that's not necessarily directed from the national. But for NCDs, it's a new area. Everybody is excited about what FBOs are doing. Actually, we are providing leadership now, and the government is excited about what we are doing. When we go to the counties, they want us to share with them what we are doing and to work together.
Thank you for your question, Mrs. Sishinga. I think we'd probably find if we talked that we define local in exactly the same way. So I couldn't agree more with what you said. The information I quoted is from the World Humanitarian Summit commitments, the so-called Grand Bargain. And they haven't included in their current statement an actual definition, although it does refer to the aspiration to move from 0.2% resources that are currently allocated through the UN system and the big donor system to 25% to quotes unquote local and national partners. I just think it's extremely important that in particular, those who are leading local partners become even more vocal than you already are about what the definitions and the standards are. I would just really encourage it. I mentioned the encouraging sign of seeing this now very well funded by Rockefeller and by Gates Foundation, new NGO, Global South NGO network that is focused on local partnership. It's called the NEAR NGO network, and I'm sure that there are many others. But these are the kind of entities that need to be seen, they need to be active, they need to be heard in terms of setting criteria, making demands, making it clear where the locus of control and the locus of responsibility needs to lie. So this is only a first small step, but I think the challenge, the opportunity is to exploit it because it's a movement. And I'm sorry that our colleague from USAID wasn't quite sure which particular frustration you were referring to.
Well, there's a lot, I mean, just culturally, so we have a South African-led project.
Yeah.
Managed at the headquarters level in Washington.
Yeah. In HIV.
Yes, in HIV, and wanting to make that shift towards self-led projects. We've just had a lot of project management frustrations just with how, just with doing business. And wanting to really make this project a success and make that shift towards sustainability, but then also having the donor responsibilities of making sure that all of the T's are crossed and the I's are dotted. And so I'm just curious from a faith-based perspective, how do we continue to encourage, and as a donor organization, how do you keep making strides towards that and not get frustrated and make sure that we're still continuing to move forward and not just give up and say, oh, this is too hard.
Well, my colleague Shepard Smith would be much better set to speak to the HIV experience, but I can speak from my own experience in Mozambique, where I had the privilege of accompanying a Mozambican faith-based partner through the process of being directly funded by USAID from 2007 for several years not being funded through intermediaries for 5 years, and now to direct funding. And from the point of view of the local partner, it was a complete nightmare because the donor expectations basically didn't change. And so, I mean, for any of us organizations, it would be incredibly difficult to meet the donor expectations, even with all of the resources that we have. It was an extraordinarily difficult process, and I think we've mentioned capacity building, but I think in terms of frustrations on all sides, to continue to move in this direction, organizations like USAID are going to have to get a lot more savvy about capacity building to meet the capabilities and the potential and the real needs on the local side. And I know that on the one hand, we've got Congress breathing down our necks, holding you to account for every dollar, and rightly so. But as I say, I went through a long and very, very painful process of accompaniment, and it just seemed to me that this process of dovetailing from the agency to the local partner we were on different planets. It was extremely difficult. I'd love to talk to you about more specifics, but that's just my own personal experience. Thank you.
Can I comment on that? I'd like to comment on the 0.2% to the 27% as representing one of the local organizations that's being exploited by that. When you use the word exploit, Sanru NGO. Sanru was started as a project. It evolved into a program. In 2011, it was encouraged by the government to become organized as an NGO so that Sanru could replace UNDP. UNDP was the principal recipient for most Global Fund money coming into Congo. They wanted to see that replaced by a local NGO. Sanru became that local NGO and currently manages about $100 million a year as grants manager coming in from Global Fund. That's great. That's that kind of transition. But what they're not willing to do is to give indirect cost rates. And it's the same thing with USAID. For the last 10 years, projects from USAID have said, at the end of this project, we want to be able to contract with local organizations. but there's never a willingness to give the local organization an indirect cost rate. Now, I understand the difficulty in establishing indirect cost rates with USAID, but if they're really serious about working with NGOs, they need to include more capacity development of the NGOs to do that.
Thanks to all of you. It is clear that we've gone over, but that is just affirmation of how important this time together is and how important it is to continue to connect. Wow, that got a buzz going here, Frank. So if you would pray with me as we wind down. Mother and Father of us all, we pray for your people, for all of your people. We pray for those who suffer, who grieve, who long, who are in need. We pray for those who discern how best to help. We pray for those who would serve you and don't know how. We ask, God, that you would guide each and every one of us in this space on our own path towards serving you and loving your people and serving your people. But we ask also, God, that you would be with us as we partner together, each of us one member of your beautiful body. Help us to take this seriously, God. Forgive us when we have not collaborated, when we have not listened, when we have not seen, when we have not been willing to truly walk hand in hand, meet face to face, connect heart to heart. Be with us now, and may we always, always choose your preferential option for the poor. Always. And give us strength for this journey, reminding us that it is not just lifelong work, but indeed generational work. It is in Jesus' name that we pray, and all who could said together. Amen.